Okay, it looks like everyone's here. So I'm Jennifer Morani. I work in marketing for U of L Health, and I welcome you today to Horses Aren't the Only Thing That Needs to Be Fast. Learn the signs and symptoms of stroke and why you need to react quickly. It's our pleasure today during National Stroke Awareness Month to have Carrie Moore speak. She works in the Department of Neurology at the University of Louisville, assisting in the development, growth, and ongoing certification of U of L Health at U of L Hospital Comprehensive Stroke Center. She serves on the Department for Public Health, Heart Disease, and Stroke Prevention Steering Committee, and chairs the Kentucky Stroke Quality Improvement Project, focused on statewide stroke systems of care. Carrie participates in nationally recognized stroke clinical trials and independent investigator-initiated projects, with her work presented at the International Stroke Conference and the American Academy of Neurology. Her clinical duties include serving as an acute stroke telemedicine provider, which has been really important with COVID, patient stroke and cerebrovascular disease clinics, and leading a multidisciplinary cardiovascular risk clinic focused on blood pressure, self-management, and lifestyle modification. Again, it's our pleasure today that you're here, and we'll turn it over to Carrie for our presentation.
All right. Well, good afternoon, everybody. I'm so excited to see your faces, and I'm thrilled. Everybody's learned how to use Zoom in these virtual meetings, haven't they? Whether we wanted to or not, we've figured it out. So thank you for those that can to share their screen that are. It certainly makes it easier when you see faces. You don't feel like you're talking to a black hole. So we'll jump right in, and let me just share my screen. Jennifer,
Yes,
sorry.
Carrie goes to share a screen. We're going to have questions. You can use your chat if you've got some questions. We've got team members on that will help answer some questions. And then we'll also address those questions at the end. So everyone is on mute while Carrie presents.
All right, so you should be seeing some slides at this point in time. Is that accurate? Okay, very good. All right, so as Jennifer was saying, horses aren't the only thing that need to be fast in the state of Kentucky. And today is Stroke Awareness Month, and time is brain. Now, we're all very familiar that in Kentucky, we're known for a few great things. There's more than what's on my slide, right? So that's really great because we're known for a lot of things. We have famous Hollywood stars. We have world-renowned journalists and authors. I mean, we are famous for our bourbon trail all over the world. People are coming in for tourism. We might be a little bit passionate about our basketball, and we have a wonderful cave system, and we have ingenuity in our state. We also have Hall of Famers, don't we? And we have one person that is known as the greatest of all time and is a boxing legend, came right here from Louisville in our great state of Kentucky. And we also are famous for the Louisville Slugger. But if we're going to strike out stroke or knock out stroke in the land of baseball bats and boxing legends, then we have to be great at knowing what the signs and symptoms are of stroke so that we can react quickly and seek treatment. But we also have to be champions, not just in sports, but champions for our health, for ourselves, for our family, and for our friends. So today, what I hope we can get across and discuss is what is a stroke? What are the signs and symptoms of a stroke? What are the most common risk factors that can contribute and increase the risk of having a stroke? What are the treatment options, emergent treatment options? And finally, leave here knowing the importance of recognizing and knowing your own numbers. And before we jump into it, if you'll indulge me, I'd just like to share a short video with you.
You know me.
That's a good question.
You see people like me every day. But would you know when to act? If I couldn't think clearly or find the right words, what would you do if I suddenly couldn't feel my arm and couldn't walk straight? Would you know this is stroke?
So that's the question, right? Would we recognize a stroke? Would we know what we are seeing? So what is a stroke? Well, a stroke is a vascular event. So what does that mean? Well, it means it's a disease that occurs because of a problem with a blood vessel. And it's an abrupt change, sudden onset of neurological symptoms or problems that are due to a vascular insult or blood vessel issue. So when we look at blood vessels, okay, I'm talking about the arteries that supply blood flow to the brain. And this originates here. You can see this is the arch, the main artery that comes off of our heart. And then these are the arteries here that comes into our arms, one on the right and one on the left. And then our carotid arteries, where you take your pulse, those come up the side or the front on both sides. And then we also have blood vessels in the back of the brain. So that's outside of the skull, but they travel and bring the circulation inside the skull. And these are the large vessels as well. You have, of course, large arteries on the left and large arteries on the right, okay? And these are pictures that we can take radiographically to assess the blood flow to the brain if we need to. So when we think about our blood vessels and the types of strokes that you can have, we can have bleeding strokes or hemorrhagic strokes, or you can have ischemic strokes or strokes due to lack of blood flow to the brain. And when we're talking about the bleeding kind of strokes, if you look at this picture here on the left side, what happens is the blood vessel will begin to bulge and then it can break open and blood products leak out into the actual brain tissue, okay? So this is an example of those large vessels that you just saw where we can take pictures of them. And then you have, think of it like tree branches where you have smaller blood vessels that also come off that we can't necessarily image with our gross imaging techniques, but we know that they're there taking blood flow deep within the brain tissue. So 10% of strokes occur when there's bleeding into the brain tissue. All right. Another type of bleeding stroke is subarachnoid hemorrhage. This accounts for 3% of strokes, so it's rare when it comes to the total number of strokes that we have. And what does this mean? Well, the layer between, so you have the skull and then you have layers of tissue or structures between the brain that help protect it. And when you have an outpouching of your blood vessel called an aneurysm can rupture a balloon-like structure that then breaks open and blood goes out into the space between the brain tissue itself, okay? So when we talk about hemorrhagic strokes, we're either talking about spontaneous, suddenly occur without any trauma, because that's different, okay? But blood in the brain tissue or blood in the spaces between the brain tissue. Now, by far, the most common types of strokes are strokes due to lack of blood flow to the brain, all right? It accounts for 87% of all strokes. And it occurs when blood flow is reduced to that brain tissue, and that brain tissue cannot survive without the oxygen and nutrients that blood flow gives to it. And here in this picture, you see this normal diameter, wide open blood vessel. But as plaque begins to build up, or atherosclerosis, or hardening of the arteries, that's what contributes to the lining of the blood vessel wall becoming narrower over time. And we're going to talk about things later that help contribute to this, all right? But eventually, if that narrowing of the blood vessel gets so severe that the blood flow is having trouble going through it, and our products that come through in our blood vessels are having trouble flowing through, then they begin to stick along this plaque and gunk that has built up. And clots can form on there, which is what you see in here, a picture of a blood clot. Now, alternatively, you can have a blood clot come from somewhere else in the body that's traveling through the circulation, and it can get stuck in between areas of plaque and occlude blood flow to the brain. And then an additional area of cause is you can have a blood clot that doesn't get stuck in this plaque, but rather comes out of the heart or from somewhere else, travels up the arteries to the brain and then lodges in those blood vessels and causes a stroke due to blockage of blood flow to the brain. Okay, and we have bleeding strokes, and then we have by far the most common strokes, which are strokes due to lack of blood flow to the brain due to blockage. Now, why is this important? Well, we have a whole month dedicated to it because unfortunately stroke is common. Stroke is common worldwide. Stroke is common in the United States. We have about 800,000 new or recurrent strokes every year, with almost 200,000 of those being recurrent strokes, meaning somebody has had a stroke in the past and they now have an additional new stroke. So 1 in 5 about are recurrent. Every 40 seconds, somebody in the United States has a stroke. More women than men have strokes annually. And it is a leading cause of disability. In addition, every 3 minutes and 35 seconds, somebody dies of a stroke. And it ranks 5th overall for all causes of death. Now, TIAs, I want to take a minute to talk about TIAs because a TIA is not a stroke, a transient ischemic attack. So you may have heard about this. It's just as important and just as much of an emergency as a stroke because a TIA is transient lack of blood flow to the brain, okay, that cause symptoms of a stroke. So if we can address a TIA and what caused it, then hopefully we can go on to prevent the stroke from ever occurring. And look at how many strokes we have, or excuse me, TIAs we have every year, more than 5 million, and it's likely higher. And why do we say it's likely higher? Because a lot of people don't report or don't even go to the hospital or seek medical attention when they have transient symptoms that last for 5 or 10 minutes, maybe 20 minutes. It goes away. They think, oh, I'm better. They don't seek any treatment and they don't tell anybody. Now, we need to get better at this for sure, because 12% of all stroke patients have had a TIA before their stroke. And a common practice when people come into the emergency room, when we see them and they wait to come in, they might wait hours, they might wait days. And we ask them, we'll say, well, why did you wait so long to come in? And they tell us, well, because it always went away before. And they thought that it would go away this time. All right. Now, the greatest risk for a stroke after a TIA is within the first 48 hours to 7 days and up to 3 months. All right. So that just reinforces the need to seek medical attention, even with transient symptoms. Now, Kentucky is in the stroke belt. Well, what does that mean? So you see the dark purple area on the map. Well, that's the area in the United States that's the highest incidence, so the largest number of strokes that are occurring, and the highest area of death, okay? And every time the CDC releases one of these maps, the purple areas get a little bit darker in some areas. So it's starting to expand. Ooh, ooh. Do you guys hear an echo? Something changed. Okay, that's better. So what do we need from you? Well, we need you to be fast when it comes to spotting a stroke. So what does be fast mean? Well, be fast is an acronym for the signs and symptoms of a stroke, okay? B is for balance. So if there's a sudden change of balance, can't stand upright, wanting to fall to the left, wanting to fall to the right, having trouble walking without losing the balance, having problems where some people describe it as they suddenly feel like they're drunk and they haven't had anything at all to drink. E is for eyes or the vision, sudden loss of vision, where the vision goes black or dark and you can't see. Sudden loss of peripheral vision, sudden double vision where you see two can be signs of a stroke. What about the F? Well, the F is for face. So facial droop. If you ask somebody to smile or show their teeth and one side is drooping or is no longer symmetric, or maybe they're having trouble eating or drinking and food or liquid starts to fall out of one side of the mouth, that could be concerning for a stroke. Arm, A is for arm. So if you have somebody hold their arms out and they can't raise their arm up, or their arm is falling down and not able to keep it up against gravity, that could be a sign of a stroke. S is for speech. So the speech is suddenly slurred or garbled. You can't understand it. The words are so slurred, you can't be intelligible as to what is being said. In addition, perhaps the wrong words could be coming out. Maybe they're talking, but all kinds of gobbledygook is coming out, or the wrong words are coming out. That can be a sign of a stroke. And lastly, the T is for time. Okay, calling 911 right away is critical to being fast and recognizing a stroke. So why the T in be fast for time? Because time is brain. For every minute during a stroke, 1.9 million neurons are lost. Well, what's a neuron, right? A neuron is this little thing over here. These are the nerves and the cells that help form communication and tell us what to do. It's what's helping me move my arms right now and talk to you and think and process. So if we have damage or death of our neurons, then that leads to death of brain tissue and function of that brain tissue. So what else could this look like? So we know about be fast, but what might it look like? Confusion. We often hear that that's a sign of a stroke. Well, perhaps that is somebody that looks like they're unable to understand what is happening and they're not thinking real clearly, or they're feeling thrown off. So they might just look at you kind of puzzled, or they might seem like they're having a hard time focusing or maybe making decisions, and it's a sudden change. Perhaps they have difficulty understanding and they're looking at you like, you know, their words are coming out right, but when you talk to them, maybe their response is not the same, or they're kind of looking at you like, I don't understand. Okay. Dizziness, sudden dizziness, where you feel faint or lightheaded, things are spinning and you can't walk appropriately. Okay. Again, maybe that description of they feel like they are drunk without any alcohol. And loss of balance, where their coordination is off, wobbling around. Maybe they're grabbing onto objects and they didn't need to before. And again, this all starts suddenly. Numbness. So suddenly feel like they've been to the dentist and they haven't been. The face goes numb. The arm goes numb. They can't feel it. They're feeling like it's awkward. Perhaps you might see them trying to shake it out or massage it to see if it feels better. Okay, to try to get that feeling back. A severe headache. So this is usually, you know, clap. It's like boom, suddenly all at once, the back of the head, the side of the head, thunderclap type headache that is so disturbing to them that they're rubbing their temples, rubbing their head. Okay, that is not known to be a problem for somebody. If that would occur suddenly, that is cause for concern. Again, the inability to speak, stumbling or not walking straight, vision change, okay, can't see in one eye or both eyes, and they might be looking like this, or they're kind of searching around, you know, looking for something. And then weakness, right? The arm or the leg is not functioning normally. They can't stand up, all right? They can't hold an object, okay? Anything like that with sudden weakness could be concerning for a stroke and should call 911 immediately. Now we have a whole chain of survival, but the chain of survival starts with detection. That means recognizing that there's a stroke, calling 911 so that EMS can be dispatched to treat, you know, take care of the individual and appropriately treat them. Also then getting them to a stroke center where they can be treated and assessed by doctors and nurses that are used to taking care of stroke patients, and there's stroke expertise at the bedside where decisions can be made about appropriate therapies. Some of them are medications, some of them are devices, and getting you, if you're not at the originating hospital that is the best place to care for you, then getting you to a higher level of care if that's necessary, or admitting the person to the hospital that they're at if that's appropriate. So what does all of that mean? Well, how do I know if I'm getting to the right hospital or not? Well, back in 2000, there was a movement for hospitals who wanted to become stroke centers to do just that. And in 2004, stroke center certifications occurred. And they're at different levels based on the resources that hospitals have as far as access to, everybody's access to a clot busting drug. Perhaps it's access to equipment as far as diagnosing a stroke or treating a stroke. And those are at higher level centers, a thrombectomy capable or a comprehensive stroke center. Some primary stroke centers have them, and then acute stroke ready hospitals. That's not something that you really need to worry about as far as the title of what that center's capable of, okay? But I think what really I would want you to know is that there are hospitals that have dedicated themselves to improving their processes and quality of care, to taking care of stroke patients, and they're certified by outside organizations. Now, in Kentucky, we're fortunate, and I'm going to show you how we've grown with our stroke centers here in just a second. But in other areas of the United States, over half of the US population is not within 60 minutes of a primary stroke center, okay? So when you look at our map in the state of Kentucky, and this is current as of this month, okay, we have 32 certified stroke centers in our state. Excuse me, I'm sorry, 36 hospitals in our state. And when you look by county, okay, so we're in Jefferson County, or I am, you may be elsewhere in the state. Look at where our certified centers are. And we're working hard in these areas of white where there aren't any stroke centers to develop relationships with hospitals that are there, as well as working with these hospitals to become stroke centers as appropriate. So when you look here in, and I'll just talk about the Jefferson County because that's where I'm at, we're fortunate because all of our healthcare systems, the Norton system, the Baptist system, and the U of L health system, all are certified stroke centers, okay? And all three systems can perform the treatments that I'm getting ready to talk to you about, okay? So we're very fortunate. What are the treatments for stroke? Well, when we're talking about the most common types of stroke, the lack of blood flow to the brain or the blockage of blood flow to the brain, I'm sure some of you have heard about a clot busting drug, okay? So when a person arrives at the hospital, the first thing that we're doing is assessing them to see if they are eligible or appropriate to be considered for this IV infuses through a vein in the arm clot busting drug that's been FDA approved since 1996. If they meet criteria or don't meet criteria for this, the second thing that we're looking at is, are they a candidate for what we call clot retrieval, where you can go in, a specialist can go in with a catheter and thread that catheter right up through the groin or in the arm and pull a clot out right at the location, okay? Those are the two major treatments to try to reverse a stroke or stop it from getting worse. Everybody gets medical management, okay? Everybody gets medical management. And what does that mean? Well, that might mean medications, that might mean treating, blood pressure, doing additional diagnostic tests, a host of all kinds of things that our hospitals are prepared to provide to reduce the disability of stroke and try to stop it in its tracks. So what is the clot busting drug? Well, the current clot busting drug is called Alteplase or Activase. And as I said, it's been FDA approved since 1996. But treatment is very time sensitive. The drug has to be given to appropriate people. Now, not everybody is a candidate for it because the risk of this medication is also bleeding. Okay, it's a very potent blood thinner. So some people will have contraindications to receiving this medication. But unless we get to the hospital right away, we won't know, and we wouldn't be able to offer it to appropriate people. And appropriate people to be considered are those that arrive and can receive the medication within 4.5 hours of the time from symptom onset that was observed or when the person was last known to be their normal baseline self. So what does that mean? Well, say somebody laid down this afternoon to take a nap at 1 o'clock and they woke up at 2 p.m. and were having trouble moving on the right side. We would consider their last known well time to be when they laid down to take the nap because the deficit occurred sometime between 1 and 2 o'clock. So when you arrive at the hospital, the first thing that'll be done is picture, the first thing will be done is that the team will assess you, the doctors and the nurses. And then a CAT scan becomes important to help us identify, is this a bleeding type of stroke or is this a type of stroke that's due to lack of blood flow to the brain? And then a whole process begins to determine eligibility for the clot busting drug. Okay. Well, what about clot retrieval? So clot retrieval becomes appropriate when you have one of those large vessels that I showed you earlier that we can take pictures of completely blocked. So here you can see this is a middle cerebral artery on the right and it's open. But here, look at this one. This one, there's no blood vessel coming out here. It cut off right here. So at centers that can do this mechanical thrombectomy or clot retrieval devices, and some hospitals that cannot, we use advanced imaging where we can identify the pink area here is the size of the stroke. Okay, so this is the area of the brain tissue that is dead or already infarcted. We can't save this pink area of brain tissue, but look at all of the green. The green is the entire side of the brain. Okay, now this is where it's lacking blood flow, but it is not yet dead tissue. So that means we have brain to save. And at hospitals that can do the mechanical thrombectomy, you go to a specialized area with specialized doctors, and that's where they can go up and hopefully, pull that clot out and stop that stroke from getting bigger. Okay, how do they do that? Well, they use devices like this called a stent retriever. Okay, this is a patient of ours that we had, came in with a small area of infarct, but you can see a large area of tissue over here that was impacted. They were taken. Here's a picture of the blood vessel where it's cut off. And then once that blood clot that you see here is pulled out, then blood flow is restored and all of the blood vessels are now filling, whereas they weren't over here. And this particular person had a very good outcome and was almost back to normal, by the next day with very minimal deficits and was able to go home. Okay, so these are just some of the acute treatments that we consider. All right, the IV type and then the clot retrieval type. But hopefully we would prevent people from ever even getting to that point. So I'd like to talk to you about what's really important in addition to the treatments is how do we prevent a stroke? Okay, because we don't ever want anybody to have to get to that point. Well, things that put us at risk for stroke that we can't change is aging. All right, the older we get, the greater our risk for stroke. But that doesn't mean that stroke can't occur at any age. It can. 1 in 5 people who have a stroke are under the age of 55. And in Kentucky, when we ran some of our statistics looking at stroke in people under the age of 65 with the over 20 hospitals that are participating in our stroke registry, over 40% of people that are having a stroke in Kentucky are under the age of 65. Okay. So yes, the risk for stroke does increase as we get older, but it is not just a disease of people that are in their 80s and 90s and 100s. All right. Race, African Americans, Hispanics, and Asians are at a higher risk than Caucasians and other races. Gender, as we talked about, more women than men have strokes, and more women die from their stroke than from breast cancer every year. And it's true. If you have a family history of stroke, then that can increase your risk for having a stroke as well. All right. So these are things that we can't change or modify. But the good news is the vast majority of things that put us at risk for having a stroke in the first place, we can change. We can do something about it, and we can decrease our risk. Well, what are those things? High blood pressure, number one. High blood pressure is the number one killer in the entire world. It is also the number one cause of heart attacks and strokes. High cholesterol, if we can control our cholesterol and some of our diet choices that we choose to intake, then we can control our cholesterol. Diabetes and high blood sugar, if we can decrease our sugar intake and prevent diabetes, or if we're a diabetic and we can control our blood sugar, then we can reduce our risk of stroke. If we're not physically active and we become physically active, now there's a spectrum to physically active, and we'll talk a little bit about it, okay? But if we can increase our physical activity, then we can take a step towards decreasing our risk for stroke. Smoking, if we stop smoking immediately, we can decrease our risk for stroke. Poor circulation, if we have other areas of atherosclerotic disease, perhaps somebody's had a heart attack before, perhaps they know they have peripheral artery disease in the legs, then that would increase the risk of stroke. And obesity, okay? Obesity also increases the risk of stroke and leads to high blood pressure, diabetes, as well as other problems with our health. And atrial fibrillation. So atrial fibrillation is an abnormal heart rhythm where the top two chambers of our heart don't pump normally. Instead of opening and closing like lub-dub, 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 they're quivering. So you get extra beats and you don't get that nice opening and closing of that top two chambers of the heart with the beat. And that can cause blood flow to become sluggish and clots can form and travel up to the neck. So if that's something that is in your health history or one of your family members' health history, then that's something to talk to the doctor about and make sure everything is being done that your healthcare provider thinks to prevent you from having a stroke. So it probably won't come as a surprise to you in Kentucky compared to the rest of the United States. We're exceeding the national average in the most common risk factors for stroke, with high blood pressure, high cholesterol, tobacco use, diabetes, and obesity, as well as some of our dietary choices. The United States is in green and Kentucky is in blue. So we have room to improve and we have opportunity. Remember that I told you strokes can be prevented. We could prevent over half of all strokes if we could control blood pressure. This is not new information. We've had repeated studies, but this is back from 1995. And what we see, and you see it, you see the messaging that comes out with ad campaigns, could be from the American Heart Association, could be from the Kentuckiana and Southern Indiana Stroke Association, could be from your hospitals, your doctors, could be from the Know Your Numbers or the Million Hearts or the Centers for Disease Control. We have all kinds of educational encounters out there through media, on the TV, in the newspaper, from our healthcare providers. looking at how can we control high blood pressure? How can we control cholesterol and diabetes and get people to not smoke or stop smoking? But instead, some of what we see in Kentucky and nationally is that instead of these numbers going down, some of these numbers are continuing to elevate and go up. So this is our opportunity to take control of our health and talk to our family members and ourselves. Sometimes we have to have a conversation with ourselves about how we can make improvements. So if we're going to knock out stroke, we have to know our numbers, right? So what are those numbers that you need to know? Well, what is your current cholesterol levels? Okay. For those who have never had a stroke or never had a heart attack or other indication from their doctor to have lower levels, a total cholesterol should be less than 200 milligrams. Okay. Now, cholesterol is important because we have bad cholesterol, which is LDL or lethal, and we have good cholesterol, which is HDLs or healthy. Now, our body will generate and make the cholesterol that we need to circulate in order for us to function healthily. The majority of the bad cholesterol that comes in that causes our levels to elevate is due to dietary choices, okay? So optimally, the bad cholesterol would be less than 100. And then you can see here, as that number elevates, the risk for forming that atherosclerosis and that plaque in the lining of the blood vessel walls goes up. Now, the healthy cholesterol, or the HDLs, the good cholesterol, we want that number to be high because the healthy cholesterol helps remove the bad cholesterol. And the goal for men is to be above 40, and the goal for women is to be above 50. All right. And triglycerides, we would like those to be less than 150. So these are the fats, for the most part, that are circulating, less than 150. Well, what should a normal blood pressure be? Well, for the general population, ideally, a normal blood pressure would be the top number less than 120 and the bottom number less than 80. We're going to talk more about blood pressure. Glucose or blood sugar. So your doctor may check your labs and they may say, I'm going to check a glucose level on you or your electrolytes. And where we would like to see that is less than 100. So when you're fasting, so it's important when your doctor or healthcare provider asks you not to eat or drink before you go and have your blood work, this is one of the things that they may be looking at, your glucose level and your cholesterol levels or your lipid panel, okay? Body mass index, that's obesity, all right? That's our height and our weight to calculate a score based on what is a standard model for healthy. And the standard model for being at a healthy weight is a BMI less than 25, okay? Waist circumference. Ideally, the waist circumference for a woman should be less than 35 inches, and for a male, it should be less than 40. And the current recommended amount of exercise is a minimum of 30 minutes on most days, if not all days of the week. Okay. Salt is always a question I get, so I put that in there. The daily recommended salt intake by the Centers for Disease Control is 2,300 milligrams per day. All right. Now, the American Heart Association is lower than that. All right. So there's some discrepancy in there, but the point is a high diet in sodium or salt is not necessarily good for you. What does our data look like for high blood pressure? Because recall, high blood pressure is the #1 killer and it's the #1 cause of strokes. And if we could control high blood pressure, we could prevent half of all strokes. So in Kentucky, currently, 42, based on our 2019 data, questionnaires that go out to people in our state, and the question is asked, have you ever been told by a doctor, a nurse, or other health professional that you have high blood pressure? And the responses have come in. Overall, 41% of Kentuckians have high blood pressure. 43% male and 39% female. Black and white, Caucasian, 45 to 42%. And yes, as age goes up, so does the percentage or rate of high blood pressure. Okay. And here we have it mapped out by the way we categorize our regions of our health departments. And so you can see based on where you live in Kentucky, what the percentage of people are in our geographic area that have high blood pressure. So what do those numbers mean? Well, the top number, or the systolic blood pressure, is how hard the heart is having to pump when it pumps blood flow out of the heart and into the blood vessels, okay? The diastolic, or the bottom number, is how hard the heart has to work while it's resting in between beats and filling back up with blood flow to pump out. Either one of these numbers being too high causes damage to the heart as well as the blood vessels over time. And know, and I'm sure you've heard, that we call high blood pressure the silent killer, because it's not until the blood pressure gets at a dangerously high level that we begin to experience symptoms. So what should your blood pressure be? And what are the stages of high blood pressure? Well, normal, again, less than 120/80. Pre-high blood pressure, 120 to 139 over 80 to 89. Stage 1 hypertension or high blood pressure is once you get into the above 140/90. And then you can see stage 2 at 160 or higher, or 100 or higher on the bottom. And then dangerously high levels once that blood pressure is reaching higher than 180 on the top or higher than 110 on the bottom. Most healthcare providers are still using information like this. Now, there was information that came out in 2017 that lowered or changed this pre-hypertension level or pre-high blood pressure levels to actually considering it a diagnosis of high blood pressure. So your healthcare provider may have talked to you about this, but as far as getting a standardized approach nationally, and even in our own state right now, we still have some providers that look at treating blood pressure with medications once the top number's over 140 and the bottom number's over 190, or some that if you're over 130, they want to be really aggressive and may want people to be on blood pressure medication at that level. So what does all this mean? Well, what it means is if you have the ability, we would like you to monitor and record your blood pressure at home. So we have more than just the number that we get at the doctor's office or when you see a healthcare provider, because in your natural and normal environment, checking that blood pressure is important to seeing an overall trend. There are tools available where you can record your blood pressure at home and practice getting it in the right category so that you can have a discussion. One of these tools is through our Department for Public Health and the Heart Disease and Stroke Prevention Program. Some of you may even participate in it at some of your healthcare providers throughout the state, where you get an educational encounter and have a booklet that looks like this to record your blood pressure. If you do have high blood pressure, what can we do besides taking medication to help lower our blood pressure? Well, we can make some changes in our lifestyle. And of course, all of this should be discussed with your healthcare provider about what's appropriate for you. But there are things that we can do to work on losing weight if that's contributing to our high blood pressure. Changing some of our diet. A DASH diet is a common proven diet that helps lower blood pressure. Changing the amount of salt that we take in, increasing our physical activity, and looking at things like alcohol consumption can all lower our blood pressure. And here you can see, by making these types of modifications and discussing what would be appropriate with your healthcare provider, the amount of reduction or range in reduction or reducing the blood pressure that we can achieve just by making lifestyle changes. Well, how do we eat better? You know, I mean, that's hard sometimes. What should we be doing? Well, we need to be looking at how many vegetables and fruits are we getting in our diet. It's recommended that we get at least 5 servings or 2.5 cups of vegetables. And those vegetables can be fresh, frozen, canned, and dried. But keep in mind that fresh vegetables and frozen vegetables typically have less salt in them. All right. Fruits, fresh, frozen, canned, dried, just watch the sugar. So again, fresh or frozen is better. Whole grains, watching the dairy that we take in and having low fat dairy, proteins, lean proteins, fish, poultry, eggs, nuts, beans, legumes, those types of things are healthier proteins. And then looking at our oils. So not bringing in the trans fats, but polyunsaturated and monounsaturated. Don't worry about all of that. But talk to your doctor about what they think would be better choices for you if you even need to make a choice. But you can do this by watching how much is going in, cooking at home rather than eating out. Some programs or products even have the American Heart Association seal of approval on them with a heart check. And then things in places where you can get trapped with the salt is in cold cuts and cured meats, pizzas, soups, bread, sandwiches, things like that. Okay, so be aware of the food label. All right, and a serving size. What is the serving size? It might not be the whole package. Okay, and looking at the fats and trans fats. Okay, so that's just something that we can talk more about at a later time if you'd like more information. There's also assessments that you can do at home, online, and you guys are savvy. So if you wanted to, you could go to the My Life Check. You could just Google it. It's provided by the American Heart Association and Life Simple 7, where it looks at all of these things that we have talked about, and you enter your personal information. Now, they don't know who you are, okay? But you just put your zip code in and it tracks it and gives you a nice report looking at your overall heart score out of 10. And this person was 8.6. And it shows you where you can improve, lose weight, manage blood pressure. Now, I had to take a snapshot, but when you click on these little buttons, what happens is it gives you strategies to do that. But perhaps maybe it would give you how you could eat better or how you could get more physically active or strategies for stopping smoking or reducing your blood sugar or targeting your cholesterol. Okay. So this is a process, but it's something that we all need to be aware of and engage in with our healthcare provider and talk to them about how to eat a well-balanced diet. What should we limit our alcohol to? How can we safely enjoy regular exercise? Because what's appropriate for one person may not be appropriate for another based on your own health and personal limitations. So that's something that you should talk to your healthcare provider about. But smoking, definitely stop smoking. Maintaining a healthy weight, taking medication as prescribed. Now, sometimes what's happened is, we're having problems getting our medications or we're having side effects from our medications. And if that's the case, make sure you bring that up. Don't just stop taking some of your medication without talking to your provider if cost is an issue, etc. Because this is a long-term partnership on a journey to improved health between you and your healthcare provider. Okay, there are some tools out there. MyPlate.gov is an excellent resource for people who are into apps for their phone. It's excellent. There's recipes. It tells you what foods you can choose to appropriately modify your diet to be healthy. Again, the DASH diet and new dietary guidelines were just released by the FDA. And they're in layman's terms. So if these are things that interest you, as Jennifer said, you know, we'll have an opportunity for you to reach out. We can help facilitate getting some of those resources to you, or you can look for them yourself or talk to your healthcare provider about them. So now let's take a look at this, okay? Here in the blue, we have the most common risk factors. And what I'd like you to do is just take a quick glance and find out how many of these, if you know, apply to you in the red category for your blood pressure, or the yellow category. Because red is, you know, like a stoplight approach. Yellow is caution, and green is we're good, but red is we need to address this. So if you are having 3 or more in your red category here, this is something that if you don't have an upcoming appointment with your healthcare provider, try to get that on the books so you can talk to them about it. If you're in the yellow, that's good. You know, you're making great progress, but there's areas that you can talk to your doctor or healthcare provider about at the next appointment. And if it's all in the green, then that's great. Okay, that's where we would like for everybody to be, is in the green. All right. So let's just reiterate our focus here on a stroke with another short video.
You know me. You see people like me every day. But would you know when to act if I was unsteady on my feet? If my head suddenly ached? Or if I didn't know what was happening around me? Would you know this is stroke? The 10 signs of stroke can be subtle and sudden. If you see them, call 911 immediately.
So together we can knock out stroke if we address these modifiable risk factors and talk to our healthcare provider about them, okay? And so what we hope that you will have gained from this short presentation is the knowledge to be fast and empower yourself to recognize a stroke, educate your friends, educate your family, so that you can make a difference and get to the hospital immediately. And hopefully this is not something you will ever encounter, but if you do, you would be empowered to take action and know the right steps to take. So at this time, if you've had questions, maybe you've typed them into the chat box. One of my colleagues, Judy, here is her phone number at U of L. And if you're in need or would like any resources about things that we have talked about, you know, we have access where we can email those to you, or we can put them in the mail to you on how to manage high blood pressure, diet choices, salt, sugar, etc., on these most common risk factors. So please, if that's something that interests you or you would like more information on, don't hesitate to reach out. That's absolutely something that we can get to you. And all reputable sources, of course, the American Heart Association, our own Heart Disease and Stroke Prevention Program at the Department for Public Health, the Kentucky and Southern Indiana Stroke Association. You know, you can look on Google. The struggle with Google sometimes is there's great information there, but sometimes it's outdated, and it can be difficult sometimes to know what's the most up-to-date and what's the most accurate information. So with that, I'll stop, and I'll stop sharing my screen.
And hey, Carrie, thanks so much for the presentation. For those of you, I'm Deidre Gottbrass, stroke resource nurse there with Carrie at U of L, and have been helping answer some of your all's questions. Great questions. So some of them I was able to answer myself, but Carrie, one of them I definitely want you to address is someone asked, Kirk Vincent asked about in acute MIs, sometimes there is stunning of the heart and a loss of heart function such as ejection fraction. However, due to remodeling and such, some of that function comes back later on. So do we know about the loss of neurons and if that has similar effect in stroke, or is it lost forever? So can you just kind of help explain neuroplasticity and stuff and how that plays into that, as well as answering that?
Yeah, so that's a great question. Thanks, Kirk. So what Kirk's referencing is we have learned so much that there's misinformation out there that when somebody is disabled from a stroke, perhaps you know somebody or you've seen somebody or you have family that's had paralysis from a stroke. And at times, yes, it's true that the disability is the disability and the paralysis is permanent and there's no improvement, okay? But what we have learned over time is that there is what we call neuro recircuitry or regeneration. Well, what does that mean? That means that what one part of the brain was responsible for before, over time, with therapy, physical therapy, occupational therapy, speech therapy, we can get some recircuitry of the function of the brain and we can see progress, okay? And we're fortunate to have learned that because years ago, it was thought that, you know, the deficit is the deficit and, you know, at 3 months, perhaps there could be no improvement. So sometimes therapy was never reintroduced. But what we have learned is that it's important to keep doing the therapy because you can get recircuitry and ongoing improvement over time.
Thanks. Appreciate that.
Yeah, no problem. Thanks for the question.
Okay, next one, Carrie, is they are asking also if you will be willing to share your presentation for people to share those slides with others at the end.
Oh, absolutely. And one other thing I did want to say, because, you know, the important thing is getting the message out. So if you have a church group, if you have a community organization, it doesn't matter. I mean, if you have Bunko and you have 10 people and you want us to come in and talk to them and answer questions, we can do it because look, we can do it this way, right? We can put a video right in the room and have a question and answer session. It doesn't matter to us if it's 10 people or 10,000 people, because if we can get the message across and help get one person to the right place at the right time, then that is progress. And that's what we're looking for. So if you find yourself in that situation where you have a group of people that you think would like to have more information, then we have the resources to help. We also have resources, you know, with our great partners from the state, and Carrie Orman is here, you know, a big advocate for the Kentuckiana and Southern Indiana Stroke Association. So we can help facilitate that, and support groups. I think I saw something pop up, Carrie put in the chat for you about support groups. You know, we have numerous support groups for stroke in our city for those that have been impacted by this. So yes, we have endless resources that we can help point people in the right direction to.
Awesome. And then next question is from a familiar face, Mary Jo, and she was asking a really great question with vaping being such a big thing right now. You know, what is research showing about vaping risk with stroke? And, you know, some of their patients that stop smoking have actually switched to vaping.
Yeah.
And then when they hear some of the risk that they're hearing, they have just said they'd rather smoke. So of course they encourage no tobacco whatsoever, but you know, what are your thoughts on that?
Yes, so right, so more and more and more is coming out about vaping, right? Now I'm looking at y'all, I don't see anybody nodding their head like they vape. So maybe this is not my audience for vaping, but clearly chemical, right? I see Miss Lee's iPad over there shaking her head. Clearly, a chemical exchange for nicotine from regular cigarettes and tobacco is not proving to be a safer choice or an alternative to smoking cigarettes. So the risk for stroke and damage to the lining of the blood vessels is also clearly impacted by vaping, and we certainly aren't recommending that. If somebody smokes traditional tobacco, that they would then change to vaping or these e-cigarettes because it would be a safer. It's absolutely not proving to be that way.
Thank you. That's very helpful. And something that is, I'm on a tobacco prevention coalition locally, and actually something that we are discussing very regularly about getting much more stringent regulations on vaping materials because of that exact fact that they actually have seen the dangers of it and the accessibility of it, and a special interest to young people is actually affecting some of that stroke risk in young people, they think, as well. So definitely something that I think we're going to hear a lot more about soon as well. Next question, Carrie, is someone has said that, what about for those people who have blood pressure that maybe their upper number or systolic is always higher than 120, but maybe their diastolic is always in a comfortable range of 70, 72, 75. What do you think about that?
Yeah, so I think as a general rule, we know, we do have evidence and science that when blood pressures are sustained higher than 130 on the top and higher than 80 on the bottom, that over time there is development of plaque or atherosclerosis. Okay, this gunk that gets stuck in these blood vessels and narrows that blood vessel wall, right? So we know that that does occur. Now, anytime there's disagreement between experts on should it be 130, should it be 140 before we start medicine, should we start tweaking blood pressure, that just means that the scientific community is not yet convinced that we have enough evidence to be that aggressive. So if somebody has had a stroke, though, or a heart attack, and we don't have a reason to keep the blood pressure elevated, then we have clear evidence that titrating medications to keep that blood pressure less than 130 over 80 is important. Now, saying that, if most of the readings are in the 110s and low 120s, we certainly don't want to cause low blood pressure to the point of where people are feeling dizzy or lightheaded, because that in itself is a problem, okay? So if the blood pressure is comfortably running in the 120s and the low 80s, I don't think there's strong data to say we should be increasing doses of medication. Another point that I would like to bring out, in our older patients, okay, so once people start to reach the age in the 70s and the 80s, sometimes for good blood flow and perfusion to the brain, we need a higher blood pressure, okay? In order to think clearly, in order not to feel dizzy, and in order to have good balance. So that's why these are just general guidelines, okay? Everybody is specific. So if your doctor is telling you, well, you need a blood pressure of X, Y, and Z, or I'm happy with your blood pressure being in the 130s, then that is likely okay for you. Where we pretty much can all agree is blood pressures in the 150s, 160s, 170s, 180s. Blood pressures that high need to be treated because those typically are not good blood pressures or beneficial to anybody. Oh, Deidre, one other thing, and that's the reason to monitor that blood pressure at home. Okay, if you have a cuff, monitor that blood pressure at home so you know what it's running on a regular basis. Sorry, Deidre.
Absolutely. No, great points. And as the world is opening back up again too, if you don't have a blood pressure cuff at home and don't have access to it, doing those pharmacy checks or Walmart blood pressure checks as you are able to also will help kind of keep track until you can have your own monitor as well. I think the next question I have is, so sometimes medication, it seems like, is used as a long-term treatment. Does it sometimes eventually become ineffective? Or, what if your medication isn't really seeming to improve the numbers? Can you help us understand what the options are when it comes like that?
Yeah, exactly. So sometimes I think it can happen, but it's really rare that a medication can no longer be effective, but there are things that can change in our body that would cause certain medications to become less effective. So that is a possibility. The other possibility is that, sometimes, unfortunately, we do need to keep our numbers and talk to our healthcare provider about our current medicines. Some people need 2, 3, 4 blood pressure medications to keep the blood pressure under control. That does happen. I see people in my blood pressure clinic, with the family health centers, that absolutely, that is a need. But what we also work on there, and I think what's appropriate is, yes, some people do need that number of medications, but that's when the lifestyle changes come into play. Okay. And that's where the individual discussion with what can I do besides taking this medicine that could help lower my blood pressure? Okay. And I think that's critical, especially in this time. I mean, it's hard out there in the primary care world, when you go in to see the doctor. I don't know if it's your case, but I'll use my mom and dad because they're not on here. My mom can have one problem when she's going in, right? She might have 3, but in the appointment today, we got one problem because we have 15 minutes to try to talk about it. So that's where, be prepared, have a little list, get it in there, or send it to them, I mean, unfortunately, sometimes it's a reality some days, but trying to engage in that conversation would be very beneficial.
Thank you so much for answering that. And then another question that kind of came up is about migraines. What about migraine headaches and their relativity to stroke, and thinking of both regular migraines and ocular migraines, both, please?
Sure. So yes, migraine is actually a vascular problem. There's a vascular component to migraine that causes the pain. So it's the vasoconstriction and the dilation of the blood vessels that's causing and releasing pain peptides that actually causes the migraine. So migraine is a vascular problem. Now, we do know, especially in women, okay, so there's migraines, and then there's migraines with aura. Okay, so what's a migraine with aura? Well, a migraine with aura is where you get symptoms. Something's telling you that your migraine's going to come on. Okay, that can increase the risk of having a stroke, a migraine with aura. Sometimes migraines can actually cause stroke symptoms. All right. And if we smoke and have migraines, and sometimes take oral birth control pills that have estrogen in them for younger people, that too can increase the risk. So yes, there is an association when people have migraines with an increased risk of stroke.
Thanks. I think more than anything, I think you have answered all the questions that I have seen in the chat, or I have given some answers out also, but I think I've had you address most of everything on here. And just a huge thank you, Carrie, for your time and info on this. I hope that people have found it informative, and there's a couple different thank yous in here, and just telling you, great presentation, Carrie. So thank you, guys.
Deidre, I was going to mention, somebody asked about how often they should take their blood pressure. Carrie, I didn't know if you wanted to tell them that. That might be good.
Yeah, good question. So how often? Well, funny you should ask, because actually in our statewide group of people with standardized messaging on the Know Your Numbers, just did a research on this to find out what is the best practice on this. Well, all the different bodies that give recommendations have provided 4 different approaches and recommendations for this. So if you are somebody that is running my recommendation, okay, this is my recommendation based on what's out there. If you are somebody that your blood pressure is running in the red, okay, you're 140 or higher on most days, or the bottom number is 90 or higher on most days, then I would recommend that you check your blood pressure twice a day, once in the morning and once in the evening. okay? Now there's a whole process to checking your blood pressure, all right? Don't just have gone out and got your groceries and come running back in. Don't just have come up the steps, or, you know, if you need to go to the bathroom, if you just smoked a cigarette, all of these things elevate the blood pressure. So we have to be at rest, all right, for 10 to 15 minutes, sitting in a chair with your arm at heart level, okay? The upper arm cuffs are more accurate than those wrist cuffs, okay? So an upper arm cuff if you have it, and record that blood pressure. And if it's running in the red most of the time, twice a day for a week or 2 weeks, then I would reach out to your healthcare provider and let them know that you've been checking your blood pressure and it's running high, okay? If, however, most of the time your blood pressure runs in the 130s or the 120s or the 1-teens, then I think you could get away with spot checking it 2-3 times a week, all right? Don't obsess about it. I have had people, like, after we've talked, you know, they'll obsess about it. They'll get a high number and then they'll check it 20 minutes later, and then they'll check it again in 15 minutes, and then they'll check it again. Don't obsess about it, okay? The point is to be aware and know what your numbers are so that you then can inform your healthcare provider. So if you're in an uncontrolled range, I would check it twice a day for a couple of weeks, as long as it's staying uncontrolled, and work with your healthcare provider to get it under better control. If it's running in the 120s, 130s, 1-teens, or excuse me, 120s, 130s, I would spot check it a few times a week. And if you see it starting to elevate into that red zone, notify your provider. If you're running in the 1-teens almost every time you check it, or low 120s, I'd check it a couple times a month. Make sure you're staying, you know, in that green zone and everything's good.
Awesome. Thank you, Carrie, for following up to that as well. Sorry. And thank you, Kirk, again, for helping me. I said I was struggling looking at the chat and asking you questions at the same time. So
No problem.
I think that covers most everyone's questions. They are asking about how we'll get the presentation to them, and I will refer that to Kristen or to Jennifer.
Yeah, Carrie, if you just send me the presentation, then I can send it out to everyone's emails.
No problem. Yes, I'll do that.
Yeah, we can always do it as a PDF to make sure the file is small enough.
Awesome. Perfect.
Oh, yeah. Well, thank all of you. You're the most important. Thank you for your time and for being here today. And I hope you have a great rest of the week.
Yes, and as Carrie said, just a reminder, with it being Stroke Awareness Month, that we hope that this has made you a little more aware of stroke, but also that you'll be able to share a piece of this knowledge with other people that you interact with regularly. And if there's any way or any place that we can ever come and bring more knowledge to those areas about stroke, please don't hesitate to reach out to Judy's phone number, or else you can email the marketing group also at marketing@uoflhealth.org for more ways to get in contact with us there. So thank you guys so much.
Thanks.